Good afternoon. My name is Jean Mures. I'm a professor of primary care in Maastricht University, and I welcome you all after your enormous travels to Maastricht. And congratulations that you arrived at this place. And hereby I open this academic ceremony in which Supriya Thapar will defend the academic thesis called Physical Activity and Lifestyle Behavior among School-Going Adolescents and the Impact of the COVID-19 Pandemic. So, Mrs. Candidate, may I invite you to present a summary of your study within 15 minutes and the conclusions of your thesis.
Good afternoon, dear Prorector, my supervisors, members of the Defense Committee, my colleagues, friends, and family. In the next 15 minutes, I present to you a summary of my thesis. Over the past few decades, global trends in overweight and obesity have increased not only in prevalence, but also at the timing of onset. Evidence indicates that excess weight has now increasingly been observed in earlier years of life, with many children entering school with lower BMI trajectories. Overweight and obesity is highly also being a problem in the developing countries, while the comorbidities of childhood obesity, such as hypertension, diabetes, and dyslipidemia, may present itself later in life. Its risk factors, such as physical inactivity and unhealthy dietary habits, may start developing during earlier stages in life. In this context, adolescence represents a critical intervention window wherein healthy behaviors of physical activity and dietary behaviors that are established during adolescence are likely to be translated into later years of life, influencing long-term cardiometabolic health, bone and muscle strength, better academic performance, and better social skills. Physical inactivity is the fourth leading cause of deaths worldwide and is a risk factor for non-communicable diseases, because of which it is already considered as a pandemic. Globally, 80% of adolescents were inactive worldwide, and in India, 74% adolescents were physically inactive in 2022. Although 80%, that is about 4 in 5 adolescents, already had insufficient physical activity levels, this situation may have been exacerbated during the COVID-19 pandemic due to home confinement and school closures. With the overarching goal of physical inactivity in adolescents, our primary research question was to assess the impact of the COVID-19 pandemic on physical activity, sedentary, and dietary behaviors of school-going adolescents. We discussed further the determinants of change in physical activity from before to during the pandemic. Further, we also discussed how we can create enabling environments for physical activity, followed by comorbidities of obesity in children and a lifestyle intervention. Chapter 2 discussed the methodological approaches that were used for the studies presented in this thesis. The study was conducted in Mohali city of Punjab in the northern part of India. Without going into details of what was not done, I think it is important to mention that the study was planned as a cluster randomized trial, and baseline data collection was done in the year 2018 to 19, and an intervention was planned which could not be carried out because of the school closures. The study was then redesigned, and COVID-19 related governmental measures were taken as a natural experiment. And the new aim was to assess the impact of the COVID-19 pandemic on physical activity, sedentary, and dietary behaviors of school-going adolescents. We assessed this using subjective measures, wherein the global school-based student health survey was used, a modified version of the GSHS 2006 questionnaire. Physical activity was also measured objectively with the help of an accelerometer over a 7-day period, which was on a subsample. Anthropometric measures of height, weight, and waist circumference were also taken. Then we also had focus group discussions to have a better understanding of reasons for the lifestyle behaviors, the barriers and facilitators of physical activity, and the possible opportunities for the changes in behavior. So the sample size was calculated as a cluster randomized trial in which one school was taken as one cluster. So we took 44 adolescents per school. With 20 schools, the sample size was calculated as 880. Now, when we actually went to the schools, because of ethical reasons, we had to take all of the students because of different class sizes, and we measured 1,086 adolescents during the baseline measures. And all of these students, we also conducted anthropometry measurements. Accelerometer measurements were taken on a subsample around for 1/4 of the population, and we had valid accelerometer measures for 181 adolescents. During the end-line measurement, we wanted to reach out to all of these 1,086 adolescents, but because of the COVID-19 pandemic and the hybrid school attendance, online and physical attendance in schools, we could only reach out to some of the students and had a high dropout rate. During the end-line measures, and finally for the data analysis, we had a paired data of 449 adolescents, and only the adolescents who were attending schools could be measured for anthropometry. And as for the accelerometer, which was already on a subsample, we had a paired data of 37 adolescents. These are some of the glimpses of the data collection before and during. This is the questionnaire and the anthropometry measurement. Now, since the COVID-19 pandemic may have led to many indirect health consequences, in Chapter 3, we assess the impact of the COVID-19 on physical activity, sedentary, and dietary behaviors of school-going adolescents from before to during the pandemic. Our primary outcome measure was the proportion of adolescents who did adequate physical activity according to the World Health Organization guidelines, that is, on an average, 60 minutes per day of physical activity. The study results revealed that from before to during the pandemic, the proportion of adolescents performing adequate physical activity dropped from 33.9% to 30.7%, which was in fact not a significant decrease. Since the study population had already lower physical activity levels to start with, maybe there is a possibility that there was not enough room for decrease. Another contributing factor could be the time period of data collection, which was during October 2020 to March 2021, during which the adolescents had already started attending schools. Another contributing factor could be the online questionnaires, which although provided an opportunity for data collection, but there could have been over-reporting of physical activity levels. We did, however, see significant changes in food intake, wherein the fruit intake increased by about 8% and the junk food intake decreased by 17%. Additionally, the changes in dietary habits comparable to those in other studies, wherein there was an increase in the intake of fruits and vegetables and legumes, but also sugar-sweetened foods and beverages. In our study, we observed that adolescents consumed more fruits and less junk food. This could be because of the closure of small businesses during COVID-19 and adolescents having no other option than to snack on fruits. Further, we wanted to understand factors associated with change in physical activity during this time. In Chapter 4, we studied a longitudinal data of 449 school-going adolescents that was collected at baseline before the pandemic and at follow-up. Factors associated with change in physical activity were assessed using a linear mixed model analysis. Findings of the study suggested that school type, that is, public and private school, is the only determinant for change in physical activity during the pandemic. There was a significant decline in physical activity in public schools during the pandemic, but not in the private schools. Besides, fruit intake during the pandemic is positively associated with change in physical activity among adolescents. These observations may help to improve our understanding in physical activity of adolescents in a lower middle income country, especially during a pandemic, and how school policy may be tailored based on the school type. Here's what the play area of public school usually looks like in India. These are actual schools where the data collection takes place. We see that there is a nice area, but since public schools are dependent on government funds for their maintenance, so it's not maybe as well maintained as the private schools, which depend on school fee for their funding. The open spaces in government schools with a right resource allocation may be converted to presentable playgrounds that attract school children to actually utilize it and become more active. Some of these differences were also highlighted in Chapter 5, which elaborates the opportunities to create enabling environments for physical activity. Qualitative data analysis reveal that despite enjoying physical activity with their friends, they are not able to do so because of barriers from their parents and teachers, such as the need to focus on academic achievement. As a result, physical education in school is often undervalued. Some of the ideas that emerged from the focus group discussions with the study with the adolescents, including elements of optimal utilization of the physical education period, making sports equipment available, and having a dedicated time for physical activity every day on a school day that may be integrated into whole-of-school approaches. Outside schools, safety concerns of playing in parks by the parents was another deterrent. This further lays emphasis on the roles of schools to take up the responsibility of promoting physical activity and other healthy behaviors in children and adolescents. Findings of the research presented in this chapter further highlight the need to create a supportive environment that encourages adolescents to engage in more physical activity. Training of teachers must be prioritized to sensitize them about the importance of physical activity in this age group, and the teachers and the community can serve as change agents in empowering adolescents to be more physically active. Since lower physical activity levels are associated with a higher risk of overweight and obesity, in Chapter 6, we evaluated the prevalence of comorbidities in Dutch school-going obese children. We assessed the effect of a lifestyle intervention between children in primary and secondary school and between boys and girls. This was done with a cross-sectional study design, including a lifestyle intervention at the Center for Overweight Adolescent and Children's Healthcare at Maastricht. Comorbidities were evaluated in 149 primary school children and 150 secondary school children with morbid obesity. Results indicated that insulin resistance, impaired glucose tolerance, dyslipidemia, and hypertension and elevated liver transaminase levels were already common in primary school children, while in the secondary school children, insulin resistance and glomerular hyperfiltration were more prevalent. The effect of a one-year interdisciplinary lifestyle intervention was studied in 82 primary and 75 secondary school children, and we see that there was a change, there was a positive change after the intervention in BMI Z-score, which was decreased, apart from total cholesterol, LDL cholesterol, and triglycerides, which also decreased after a one-year lifestyle intervention. In the primary
The candidates, you have only 1 minute left.
Right. In the primary school children, there was a decrease in the BMI Z-score and a decrease also in the BMI Z-score in the secondary children with a decrease in estimated GFR. Now, having all the information, what can be done? Optimal utilization of the physical education period must be prioritized while also ensuring that it is effectively implemented. During future pandemics or natural calamities, when students may be confined to their homes for extended periods of time and having to do online education, school policies must include a mandatory element of physical activity. Whole of school approaches to promotion of physical activity must account for differences between public and private schools in the Indian context and not have one policy for all. Lifestyle interventions in children with obesity must be introduced at the primary instead of the secondary school level. Adolescence is an important period of time in the life course of an individual, and health behaviors during this time lay the foundation of health and well-being later in life. Thereby, this thesis specifically reports the change in these behaviors from before to during the pandemic, while also exploring the factors associated with it. The findings not only help us to understand the physical activity behavior in adolescents in a lower middle income country, but also provides a roadmap for the policymakers.
Thank you for your presentation. The opposition will be opened by Dr. van der Voorn. She's an assistant professor at the Academic Institute for Public Health in Amsterdam, and her expertise is on pediatric obesity.
Thank you. Dear candidate, thank you for offering me a qualitative insight into the daily context where children and adolescents grow up in a country like India. And as you refer to in Proposition 5, late childhood and adolescence are critical developmental periods in which behavioral roots start to shape lifelong mental and cardiometabolic health. And it is therefore of utmost importance that you performed this work in this target group, and you delivered important information for policymakers that combat this pandemic, the obesity pandemic and the pandemic of NCDs. Now, I would like to start with a reflection on your introduction and the rationale underlying this thesis. And then I start with at page 10, you describe that school-based interventions have been one of the common approaches to promote PA in adolescents, and whole school approaches to PA promotion is a strategy that places schools at the focal point for providing opportunities such as PE, classroom activity breaks, recess, sports program, active transport, etc., thereby ensuring that young people achieve their daily recommended PA levels. Well, a lot of literature and evidence was already pointing towards this whole school approach when you designed your study. And when you go back to that period, I was wondering, with the knowledge you had on the low and middle income country context, what was your hypothesis that you wanted to analyze or to find evidence for? What would be different when you already saw how good whole of school approaches would work in high income countries? What the difference would be in the low and middle income countries?
Thank you for your kind words, highly esteemed opponent. and your question. Whole of school approaches, there is a lot of literature in the high income countries, and it has been quite successful, and there is a lot of literature. But as far as the lower middle income countries are concerned, there is limited literature on that, and that is the reason for the what can be done after we have this information from the study. So in India, there are many, I would say, similar things that can be done. So when I was going through the literature in the high-income countries, I did observe that the problems or the challenges are quite similar in a lower middle-income country as well. So there are many things that can be replicated, and there are some things that can be changed, So, for example, when we talk about having a cycle stand maybe at the entrance of the school, which can attract, transportation by cycling to school, that is something that can be replicated in a lower middle income country as well. Maybe if not in public schools, but in the private schools where they have more funds to do such a thing. Whereas in public schools, something like the availability of a sports equipment which is kept in lock cupboards can be made more available, and there are different ways to maybe sort of have a playground that can attract children to actually come and play there, and also a supportive social environment with the training of the teachers for sure, to encourage.
Yeah, thank you. I hear you that so there are similarities and working elements that you
Yes.
can implement in a similar way, but there are also differences. And I can imagine that it is on an individual level, a community level, but also a systems and policy level. Did you expect beforehand that so was it an hypothesis that there was another perspective on the value of academic achievements by the parents and the school teachers than by things physical activity and cardiometabolic health?
Well, yes, there is definitely more pressure on the academic achievement by the parents and the school authorities. And the schools in India, in fact, they are evaluated based on the academic achievement and not how much by the students are playing in the playground and the reason for it. But if you could maybe rephrase your question and...
Yeah, so was this something that surprised you, that this was an extra barrier more prevalent than in high-income countries, that the academic achievement was so highly rated that it would form a barrier to make time for physical activity?
In the high-income countries?
No, in your country. Was that a surprise for you?
It was not a surprise for me because I have gone through the same thing when I was in school. So to see that things have not changed a lot over the years and the focus is still on the academic achievement was not as much a surprise for me. But my only thought at that point was what can be done further than this to have that, but at the same time have more physical activity coexist with that kind of pressure.
Yeah.
So
that's a very good ambition to help to support that change towards focus on lifestyle. Yeah, I have one last small question, and that is about chapter 6, where you describe where you show that comorbidities are already common in primary school.
Yes.
In a Dutch clinical cohort and can be improved by a 1-year interdisciplinary lifestyle intervention. Well, in your context, this is very important information, but finances are little, and both will cost money, like doing the diagnosis early and for a larger group, namely already the children with overweight, or providing an intervention. What is your advice as being a policy advisor on where to invest in? Should we do more diagnostics in younger children, or should we invest in a larger amount of lifestyle interventions that are available early on already?
Right. So in this case, I do feel that maybe we could start small in a country like India and target smaller obesity clinics where the children are and adolescents with their families, they are already visiting, and do a sort of a pilot there and see what is the response of adolescents coming to an obesity clinic, because we do have smaller clinics like these, but also in larger tertiary care hospitals, we do have the obesity clinics in which the children are already coming. And it will be really interesting to start with hospitals, in the first place, and have a lifestyle intervention. And such hospitals, they are able to have funds to start with such a lifestyle intervention, and the parents who have the motivation to go for a 1-year lifestyle intervention as well.
Thank you.
The opposition will be continued by Dr. Spicht. He's an associate professor and with an expertise in prevention in primary care, and is the secretary of this degree committee.
Thank you, dear Prorector. Dear candidate, first of all, my compliments with your work, especially for collecting so many data among adolescents. I have 2 adolescents at home. I think it's very difficult to get them to do anything. So to be able to do so many measurements with so many adolescents, I really think that that is worthwhile mentioning. My question is about chapter 4, and also in your presentation, you highlighted it that the private schools, they do much better when it comes to physical activity than the public schools. So the reduction in physical activity is much less in the private schools, correct? But I'm wondering whether what you see is really, and then in your conclusions and discussion also, you focus on what do they do, these private schools, that the physical activity is reduced less. But I wonder whether it's really the effect of the private schools and that you should focus on, because these children are, for a reason, in this private school. They are from a higher socio-economic status. So their parents and their living conditions, probably also their living environments, where they live physically in their neighborhoods, is very different from those from the public schools. So are you correct in concluding that it is the impact of the private schools, or are you really seeing a lot of confounding, and is it possibly due to other factors?
Thank you for your kind words, highly esteemed opponent, and your question. So I do think that definitely there are differences between the public and private schools, but we cannot really say that it is only the difference is in the physical activity. There are a lot of other confounding factors as well, and there is a possibility, as I mentioned, of over-reporting of physical activity for private schools students as well. So, and during the COVID-19 pandemic, what we really want to highlight in chapter 4 is that there is a big difference between the public and the private schools, whether there is changes because of the COVID-19 pandemic. The differences are higher for public schools the decrease, and maybe not so much in the private schools. So that could be because of the COVID-19 pandemic alone. Maybe in a normal time, it may not have been so different. But what is of importance here is to understand that when in the future we have interventions planned, we need to tailor them according to the school type. Because of, as you mentioned, the socioeconomic background and the living conditions of both the public and the private school adolescents are different, and also the challenges that they face. For example, barriers to physical activity for private schools may be using a lot of phones, but barriers for public school children may be having not enough spaces to do physical activity. So we need to look at these differences and highlight.
Okay, I agree with you that the observation in itself of the difference between the public and private schools, that observation is important, and not so much whether it is causal or not. I think that's how I interpret also your answer. Then I looked it up because I was wondering, these children are at school a big part of the day. And so the school has a big responsibility to take care of these or my children. And so can I file a complaint to a school if the school doesn't provide a healthy environment? So I was wondering, in Netherlands or anywhere in the world, has there already been lawsuits against school for not taking care of the health of the children? And then I looked it up and I found that in India, in fact, the schools are obliged, it's by law, to provide a meal, isn't it?
Yes.
So would it not be a very good way to go to increase that law? So to lobby for maybe not even providing a meal, but providing a healthy meal, that you make classifications to the healthy meal, but also to oblige them to make a law to make physical activity facilitated, so that if they don't, that people and parents can file complaints against these schools. Is that not a way to go for India also? And also for the Netherlands, because in the Netherlands there is no law at all for food and physical activity, but at least in India you have a law for food.
Yes, actually, in fact, that is a very good idea. If it is made mandatory, it can really help. But at the same time, maybe filing a lawsuit if the school is not implementing it. I'm not really sure of that, especially with the government schools, with the public schools, I mean to say. Maybe for the private schools, it might work, but it is also filing a lawsuit in India is a very long and tiring process. So if maybe by the time there is a lawsuit, the child or the adolescent is already out of school. So it really doesn't help. And people in India are aware of this, and thereby the lower number of lawsuits. But at the same time, having a policy for mandatory physical activity or a physical education period every single day is, in fact, already there in India.
Also for physical activity?
It is there,
Okay.
but it's not implemented as it should be.
But by law?
Yes, by law it is
provided.
there. For older adolescents from 9th to 12th standard, it is there.
Yeah,
But
okay, but also again, probably only that it is there and not how much and not is what is the quality. The same as with the food.
no, the food is much well implemented. There are some lags in the food that's called the midday meal program in India, and it's quite well implemented, but not so much the physical activity because of maybe, I could say, lack of awareness, or we need more education in the community for physical activity.
Okay, thank you. I give the word back to the product.
The position will be continued online, and I ask tech support if it is really possible to... By Professor Van Mil. He has a chair here at Maastricht University, and his expertise is on youth, food and health, and he was your chair of your assessment committee. Professor Van Mil.
Thank you, dear Prorector. Thank you very much. And dear candidate, first of all, I would also like to congratulate you with the forthcoming of this impressive thesis, and would also like to congratulate your supervisors with this accomplishment as well. I would like to go with you to chapter 2, page 25. You explained to us that a natural experiment is defined by the UK Medical Research Council as an event that is not under the control of researchers, but at the same time enables us to measure the size of the impact. Therefore, a lot of researchers interested in the effect of COVID-19 epidemic would be jealous because you coincidentally ran into such a natural experiment. On the other hand, you cannot design a study that you thought that you would not be performing, of course. So my question is, in the theoretical situation that you were able to predict this natural experiment, how would you have designed the study?
Highly esteemed opponent, thank you for your question. I may not consider myself so lucky that the COVID-19 happened and I had to change the whole planning of my thesis. But at the same time, if it had not happened, then we had planned for an intervention to take place in the adolescents, and we had in fact already designed the intervention using intervention mapping and all the steps that go with it. And we wanted to have tailored interventions. Definitely, we also had the idea of having tailored interventions for public and private schools, but also, if needed, for each and every school. And we also had an idea that during the intervention, we wanted to have whole of school approaches for the intervention as well, which include having involvement of the adolescents in the planning itself, along with the teachers and the parents, so that there is a lot of motivation and there is a lot of movement towards encouraging physical activity in adolescents.
Okay, but now COVID-19 pandemic came up. Would you have been able to perform this intervention? And I guess the answer is no, of course. But what have you learned from these studies? How would you change your because this is really my question, maybe I should rephrase it. How would you change your intervention so it would be possible to perform it during the COVID pandemic?
Well, first of all, there should be, I do feel, in my opinion, that we could have more focus on screen time, which increased during the pandemic, and a lot of homework is being done online as well for both public and private schools. And I do feel there is a difference in access to the mobile phones. But there have been studies as well that talk about decreasing sedentary time. And in this case, maybe an intervention that we could have planned after the pandemic could have involved an activity that could be on the mobile phone, like there was an intervention in Maastricht, where they wore wearable devices that helped you to gives you scores and points if you are running for maybe a kilometer or something. So an app-based intervention could be an element.
Okay.
Yeah.
Thank you. Interesting. Another question, if I may, and that's about the actigraph measurements. So on page 28. You showed us that this actually was based on convenience sampling, as 7 schools decided by themselves to join this subsample. And further on, you note that efforts were made to equally distribute the actigraph usage among government or public schools and private schools. But you don't show us how this was distributed. And in chapter 3, where we do see the results of the actigraph testing, you don't mention the convenience sampling anymore. So my question is, was the actigraph measurement indeed equally distributed, or was there a large difference? And if there was, how would this be influencing your results? Because the next question, the next chapter, of course, you'll explain how these results can be explained. But first of all, the distribution. Do you have any idea how the distribution of the usage of the actigraph was?
Right. So, in fact, initially when we did the baseline measurements, we had a cluster randomized trial in mind in which we had 10 schools who were in the intervention group and 10 schools in the control group, 5 each from the public and private schools. So 5 public, 5 private schools in the intervention and 5 public, 5 private in the control group. And we wanted to distribute the actigraphs equally in the intervention and the control group, while also in the public and the private schools. So although it was convenient sampling and we did go to the schools and ask them whichever school was ready to have their students wear the actigraph, we went for those schools. But the idea behind it was equal distribution between intervention and control group to start with.
Okay, so you have a good idea that it was quite well distributed.
Yes.
Between the both schools. Okay. Because in chapter 4 you do indeed, this was already discussed before, you showed us that the school indeed is a crucial factor. So that explains that this result can be is a valid result indeed. Thank you. I'm looking at the time. Is there enough room for another question, or should I hand over?
You could ask a small question.
A small question. Okay. Let me try to find, because I have a lot of questions. Well, this one. On page 44, you mentioned that BMI and waist circumference increased during the pandemic, as we can see in table 4, appendix 1 on page 49. And at the same time, you see that BMI Z-score, age-corrected, also improving. So it almost looks like, at least for the public schools, the COVID is increasing their health. Don't you think so? They're eating more fruits and they're getting a better weight. So COVID-19 pandemic is really good for you.
Well, that was also
Small answer, please.
Right. Well, that was also our initial thought, in fact, when we saw the data. But then I think what we learned from it is maybe this is something that we can focus on in future interventions to also eat healthy. And the reason behind eating junk food was maybe because the small businesses that were available, and maybe have a control or a regulation on that, and also side by side encouraging to eat more fruits.
Okay, thank you very much. I give the word back to the pro-rector. Thank you.
The opposition will be continued, and the University of Maastricht really appreciates your speaking from India, Professor Anchala. You're working at the Indian Institute of Public Health in Hyderabad, and your expertise is on primary care and public health. Dear Professor.
Yeah, I think I must commend the candidate for despite the multiple challenges and the constraints, the study was undertaken in a very rigorous manner. I have a couple of questions on the sample size calculation, Supriya. Now, you had mentioned that this was a cluster randomized trial, and any kind of cluster randomized trial needs to take into account the design effect. Nowhere in your document or your manuscript I could see sample size calculations which were powered to address the design effect. More so because the schools are quite heterogeneous. You have 10 government, or you have 10 schools randomized to one intervention, 10 to the other intervention. The data has got a lot of heterogeneity. Why wasn't design effect taken into consideration when you did the sample size calculations?
Highly esteemed opponent, thank you for your question. Well, we did take the design effect into consideration while doing the sample size calculation for the cluster randomized trial, but this was not included in the final thesis because we had to do the sample size calculation again for the natural experiment and take the other things in account, and that sample size calculation is what is included in this thesis. But at that time, before the baseline, when we did the sample size calculation, we did take the design effect in consideration.
Okay, thank you for the clarification. The second question I have is almost linked to the first question. Your baseline sample had around about 1,000 participants, 1,090 to 86 participants, and your dropout rate is almost as high as 60%. So your final, at the end of the study, you had 449 paid samples in which you did the before and after analysis. Am I right?
Yes.
So this 60% dropout, was it similar in both private and government schools?
Well, it was not similar in public and private schools. We could reach out to more students from the public schools than the private schools during the follow-up measurements. During the baseline measurements, that was almost equal. But because of the COVID-19 pandemic, more of the adolescents from private schools were attending schools from home, while more of the public school students were attending physically at school. So we could reach out to the public school adolescents easier than the private schools. So there was a difference in the follow-up measurement.
Okay, because it becomes quite important for us to understand this nuanced aspect, because in chapter 4, one of the main determinants you found out was the type of school.
Yes.
Now, if the type of school was your main determinant and the dropout was more in the private when compared to the public schools, wouldn't that affect your results?
Well, could you maybe rephrase the question?
Okay. What I wanted to find out was, since the dropout rate was different between the private and the government schools, wouldn't that dropout be the main reason as to why you found out the school type was the most important determinant for PA?
Well, we did actually do an independent samples t-test to find out whether there was a difference in the actual measured sample and the dropout, and we did find out that there was not much difference between the actual measured sample and those who dropped out. So we can say with the statistical tests that it was not.
Okay, fair enough. I mean, attached to this question is this question that follows. Now, the anthropometric data was done for around 308 participants, right?
Yes.
So from the initial baseline of 1,068, you had dropped out to 449, then dropped down to 308. So why was it done only on around 300 participants?
We did the anthropometric measurements for all of the children who were attending schools at that time and who had baseline measures. And in that case, we could only reach out to 308 adolescents during the COVID time, and that is the reason for the dropout.
So I believe a better way, Supriya, would be that when you have such a significant dropout, you must go back and check your power calculations.
Right.
Your study was 80% or 90% power to determine the final outcome. Since the dropout is almost 60%, that would affect the study's power to find the actual truth if the truth exists in the population. So did you do a post facto power analysis for your dropped out sample size? No,
we did not do that.
Okay, if possible, and if you're trying to make this into a, I mean, of course, you'll be trying to publish the findings in a good journal. Reviewers would come back to you and definitely ask for your power size calculations so that it goes forward. Okay. Now the final question from my side would be, in your chapter 5, you did a qualitative research in which you did focus group discussions. So what were the emerging themes that came out as a surprise for you? Of course, you had 4 determined themes, which was on social environment, the type of support given by the schools or by parents during that particular time. So the question to you is, did you find any emergent themes that came which you did not think before the study started?
Well, I think that focusing on reinstating the physical education period was kind of surprising for me. Of course, we do see in literature about the supportive environment from the teachers and the parents. That is an important factor. And even though already knowing about the physical education period being implemented in India, maybe not on a weekly basis as it should be. But at the same time, while analyzing the focus group discussions from the adolescents, the parents, and the teachers as well, this was quite surprising that this really, really needs to be reinstated, and physical education period was an emerging theme.
Okay, thank you, candidate. I think if I may just to sum up one final comment from my side, what would be the main public health implication of your study? Your last slide presented those, but I would want you to go back, visit the slide again, and come out with one significant policy level implementation that you want to undertake in the schools after your study has been completed.
Yes. So I do feel that with the COVID-19 pandemic being over, and then thinking whether the study results are really relevant at this point of time, but in the current situation when there are so many natural calamities, there's war, among other things going on, and seeing that children and adolescents, they are attending, they might have to be attending schools in a hybrid mode in the future as well. So I feel that one of the very important findings of this study is it gives us evidence of how in a lower middle income country the lifestyle behaviors are for adolescents. And in the future, if such a thing happens like a natural calamity or war, what really can be done and how we can focus on physical activity. And also, in fact, maybe plan an intervention for physical activity even during, when adolescents are attending schools in hybrid mode. So that was an interesting finding.
Good. Thank you for your crisp and succinct answers. Thank you.
Thank you very much, Professor. The opposition will be continued and concluded by Dr. Couture. She's an assistant professor at Maastricht University and has an expertise in prevention in primary care with a focus on mental health.
Thank you, Prorector. Dear candidate, I also want to congratulate you on this excellent work completed in the challenging time of COVID-19. It shows perseverance and great creativity, so nicely done. However, my line of questioning will continue with the qualitative project, so chapter 5. When I look at the timeline in your thesis, it shows that you conducted the baseline measurements first. And then the next step were the focus group discussions with adolescents, parents, teachers. And as you mentioned earlier today as well, the whole of school approach is well described in literature, and the effects and how it works has been well described regarding the high income countries. But you also mentioned that the challenges are quite similar in the lower and middle income countries. And when reading chapter 5, with the discussion of your results, it seemed that most of your themes had already been described in the literature. So my question is, how come there was a choice to conduct focus groups? Why did the team not opt to do, for example, a survey, since there was already a lot known, possibly with some extra open-ended questions, so that you could assess how this all works in the sample in India?
Highly esteemed opponent, thank you for your kind words and your question. Well, if I may request to rephrase the question.
Right. So there was a lot of evidence already in literature about the whole of school approach, about also the themes that you ended up describing in your chapter 5, because you mentioned in the discussion of the chapter 5 that most of the factors that you described had already been found in other studies as well. So I was wondering what made you choose to proceed with this qualitative method of focus groups and not conducting a survey to assess if these factors also apply in your sample?
Thank you. So, in fact, when we did the focus group discussions, we wanted to find more, but at the same time, the themes, although they are similar to the ones in the higher income countries, but there are elements that are different for lower middle income countries. For example, when we look at the equipment, the sports equipment that is not available in private schools, but in public schools, but they are available in the private schools. That is something that we can do. And also when we talk about the resource allocation. So resource allocation as a theme might sound similar to the higher income countries, but when we talk about resource allocation in context with a lower middle income country like India, we see that many times the physical education teachers are not appointed in schools, which may not be the case in a higher income country, and that is something we need to focus on. So while the themes might look similar, there are certain nuances to it which are different for the lower middle income countries.
Okay, thank you. And you feel you would have missed those nuances when conducting a survey? So.
Yes, when we did the survey, we took a standardized questionnaire which did not cover these questions. And in order to supplement that information and why the physical activity is what it is, that is the reason we did the focus group discussions as well.
Okay, thank you. My next question is also on the qualitative chapter. I was wondering if you could tell us a bit more about the theoretical foundation of this method, of these focus group discussions, and also the transparency in reporting. But maybe let's start with the theoretical foundation. You mentioned earlier that you wanted to assess barriers and facilitators for physical activity. But I was wondering, how come you didn't use a theoretical framework? There are a lot of theoretical frameworks in educational literature, also in implementation science, in behavior change literature, about how to implement or help an intervention. So I was wondering, what was the foundation for your interview guide in these focus groups?
Right. So when we did the focus group discussions, our main idea was to know from the adolescents, of course, the barriers and facilitators of physical activity, but there's a lot of literature on barriers and facilitators of physical activity in high and the lower middle income countries. What we wanted to do was to move beyond that, is what are the actionable steps that can be taken in a lower middle income country, how we can reduce the barriers or increase the facilitators and move forward. What are the solutions, actionable points, was the idea behind the focus group discussions.
Okay, so if I understand correctly, you were looking for actions to be taken.
Yes.
Okay, thank you. Now, in the thesis, you also referred to the project as being a mixed methods study. Yet the qualitative and the quantitative components appear to be presented largely separate. And I didn't see a clear integration between them, not in chapter 5, nor in the overall discussion. So I was wondering, how would you conceptualize the relationship between the qualitative study and the quantitative studies?
Right. So in the mixed method studies, we first conducted the quantitative measurements and then the qualitative measurements. I think it's a good idea. We could have maybe had a paper or an article which was including both the quantitative and the qualitative. But as of now, during the baseline measurements, it was one after the other and presented separately.
Okay, and how would you integrate those data? What do they add to one another?
Right. So the quantitative measures, they help us understand what are the actual levels of physical activity, and as we see the differences in the school type. When we look at the qualitative data, we know more, of course, about the school type, but also then what kind of interventions can be done in the future, which can be different based on school type, and not only for physical activity, but also for the sedentary behaviors, which is supplemented by the qualitative data, and for the dietary behaviors as well.
Okay, thank you. Now, I referred to this earlier, but I was also wondering about transparency in reporting the study. I couldn't find the interview guide that was used for the focus group discussions in your thesis, which I was really curious about because there are so many themes elaborated in the results section that I wanted to know how did these focus groups, how were they conducted? Could you maybe reflect a bit more on how you ensured transparency and quality while reporting this qualitative study?
Right. In fact, now that you mentioned it, since we included the questionnaire as an appendix, it would have been a good idea to also include the FGD guide as an appendix as well. I agree. But at the same time, what we did was follow a process for the analysis of the qualitative data in the best way possible, and have transcripts, word-to-word transcripts taken.
Thank you, Mrs. Beadle. You can finish your sentence, if you wish.
Yes, yes, I do. Thank you. So for the qualitative part as well, we made sure to follow the process of the analysis and have word-to-word transcript and use NVivo software for the analysis. And whatever themes came out of it is the actual ones that we have included in this question.
Thank you for this long sentence. Supriya Thapar, I hope I pronounce your name well. The time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your work and your thesis and your defense, and I request that you and your company await the results of our deliberations and our return in this room. Dear Mrs. Thapar, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. From your supervisory team, consisting of, amongst other, of Dr. Winkens and Professor Vreugdehill, now Professor van Schaik is authorized to confer upon you this academic distinction in accordance with Dutch university custom, and he will also ask you to agree to a declaration of integrity. I invite your supervisor to now take the floor.
I'm first going to ask you that question. Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible? What is your answer?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Supriya Thapar, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university.
Now your supervisor, Professor Vreugdenhill, will try to give as much as compliments to you in a laudatio. There you go.
Thank you. Dear Dr. Thapar, dear Supriya, first of all, many congratulations on obtaining your PhD today. Of course, on behalf of the entire supervisory team, I would like to say how proud we are of you. And of course, I would also like to congratulate your parents who are here today. So happy that you could make it. I know how hard the traveling was. But also your family and friends who are here today or joining from afar. A PhD is never a journey taken alone, and we know how much support you have received from the people around you. Your PhD journey has truly been an international one. You've been working from Chandigarh in India under the wonderful support and supervision of Professor Thakur, while collaborating closely with our research group in Maastricht. Conducting a PhD across continents is not always easy. It requires independency, determination, and excellent communication skills. And throughout your journey, you have shown all of these qualities. Some while ago, you spent a few months in Maastricht to work more intensively with the team, who are here today, and accelerate your research. And during that time, you not only worked very hard, you also discovered some typical Dutch things, of course, like the tulip fields and the windmills and the clocks. And perhaps most importantly, Limburgse vlaai. I think it's fair to say that you became slightly addicted to it. During that period, we also organized our writing retreat with the research group, and we spent an entire weekend together, focusing on writing and discussing the chapters of your thesis. And during the day, we worked hard and made a great progress. In the evenings, there was plenty of laughter and good conversations. That retreat showed two important sides of you. You are a very dedicated and hardworking researcher, but you also know to enjoy a good celebration. Something that also became very clear during the party after my inaugural lecture, which at midnight passed smoothly into the celebration of your birthday, a memorable evening. You remember it, no? Yeah. Okay. What makes your work particularly impressive is how much you accomplished from a distance. Of course, together with Professor Thapar and with the support of Maartje, Bjorn, Anno, and myself, you built a strong research project on physical activity in children, which request trust, communication, and strong social skills, qualities you clearly have. For your research, you used the actigraphs. Getting those devices to India turned out to be quite an adventure. At some point, they seemed to take a very long holiday at customs. So, when you later traveled to the Netherlands, you decided to take matters into your own hands and simply brought them back in your very large suitcase. Sometimes science requires a little creativity, and occasionally a very big suitcase, and a bit of courage as well. So we also had the opportunity to visit Chandigarh ourselves, where Professor Thapar organized a wonderful conference, I think with your help. But you welcomed us very warmly to your city, showed us the schools involved in the research, and even introduced us to an I should say very early, morning yoga session. A very different way to start the day than we are used to in Maastricht. And I can remember how Maartje and I went crazy when we saw this monkey running on the building. Do you remember? It was unforgettable, actually. So, we were also warmly welcomed by your parents who are here today. And I'm so happy to meet again here in Maastricht. We are very grateful for the hospitality and kindness, and even more for the support that you have given Supriya during her whole journey. I would also like to acknowledge the supervisory team. Maartje played an important role in supporting you during the early stages of the PhD, and remained involved even after health challenges forced her to step back from the formal role. And I'm happy she's not here, but online with us today. Bjorn has been a wonderful teacher in statistics, and it has been great to see how much you have grown in this area. What once seemed complex is now something you clearly master yourself, and you showed that also in the answers to the difficult questions today. The final phase of a PhD is often the most challenging. For you, this was certainly the case, as you were already starting a new job while finishing your thesis. But you kept going. You stayed focused and brought everything together into this beautiful dissertation. And when we look back at this journey, from schools in Chandigarh to actigraphs, traveling across continents, to writing retreats, celebrations in Maastricht, one thing becomes very clear: your determination, your positivity, and your hard work that brought you here today. So, Supriya, or I should say Dr. Thapar, it has truly been a privilege to supervise you and witness your growth over these years. And we are confident that wherever your career takes you next, you will continue to make a meaningful impact. So congratulations, Dr. Supriya. This achievement is more than well deserved. And with that, I would like to give the floor back to the prorector.
Thank you. So Dr. Thapar, also on behalf of the whole Maastricht University, I congratulate you with the degree you have acquired, and I want to involve in those congratulations also your Appa and Amma, who are present here, and the amazing presence of several researchers from the Department of Pediatrics, who I truly admire, and of course Dr. Maartje, who is online and many greetings from this side to her. With this, I will conclude this academic session, and after the conclusion, we will remain here to make a picture together with the one left online opponent. And after that, we have the full package. We go to the stairs and make another picture with your parents, and then we go to the Vlaai, I have understood. So with these words, I will conclude this academic session.